Good morning, everybody. Although we have a lot of registrants who are still turning up, we do need to get started because we have an absolutely packed agenda today. So, good morning. My name is Andrew Grulich from the Kirby Institute at the University of New South Wales, and it's just my job to get proceedings underway today. And of course, I want, as is the custom in Australia, I want to begin by acknowledging the traditional owners of the land that we're meeting on today, the Yagara and the Turrbal people, who are the traditional custodians of the land we're on today, Meanjin, or as we call it today, Brisbane. I'd like to pay my respects to their elders, past, present, and emerging, and also to acknowledge that the land was never ceded. And in particular, I'd like to welcome and acknowledge any Indigenous people who might be with us today. So I'm one of the co-chairs of this meeting today, and the other co-chairs are listed there on the slide. Professor Adiba Kamaruzzaman from Monash University, Malaysia, Joel Pulevsky, welcome Joel, from the University of California, San Francisco, and Sinead Delaney-Moretloe from the University of Witwatersrand, did I get that right? South Africa. And I do want to start by acknowledging the sponsors for today's meeting. The gold sponsor is Unitaid, who I'm sure you're all aware do a lot of work in this space, and CSL Seqirus, as well as Cepheid. Our partners for today, there have been a large number of organisations who had input into the organisation of this meeting today, and I'd like to acknowledge them all. In opening this meeting, I just wanted to acknowledge the passing in the last year of an absolute giant in our field, Howard Zerhausen, who, of course, discovered the HPV vaccine and related it to its cause in a range of genital cancers, well, initially cervical cancer. And it wasn't always thought that it would be that virus that caused the cancer, so it was quite the discovery. And since we're in Queensland, we really should also pay tribute to another giant of the HPV field, Ian Fraser, who was the co-inventor, along with John Zoe, of the technology underlying the incredibly effective vaccine, which has transformed this field, and the self-assembly of the IL-1 protein, which forms the basis of that vaccine. With that, there's my conflict of interest disclosure. And sorry, I can't read that. So. Thank you. Thank you very much. With that, I will hand over to the chair of this first session, Adiba Kamaruzzaman. Thank you, Adiba.
Thank you very much, Andrew, and good morning, everyone, and welcome to this actually first pre-meeting that the IAS has put together on HPV and HIV, and we're really delighted at the response we've received from both speakers who've most had agreed to join us this morning, and hopefully, as the room fills up, people literally from all corners of the world. And when Andrew and I and Sinead and Joel were designing this program, we really wanted it to encompass knowledge and best practices from not just the HIV and HPV world, but also to learn from the great programs that are happening all over the world in an effort to eliminate cervical cancer. So hopefully you'll all agree with me by the end of the day that this will be a rich program that we are learning together for the first time in IAS's pre-meeting on HPV and HIV. So that's the program that we've put together, that in the first session this morning, that we will learn of the scale of the challenges. Although we've had a very good vaccine for many years now, there's still lots of mountains to climb in both the general population as well as people living with HIV. But there have also been a lot of science around it, which hopefully we will hear in the state-of-the-art guidance for vaccination, screening, and treatment of HPV in both people living with HIV as well as the general population. We will then hear about best practices from around the world on programs to eliminate cervical cancer. And with that, in the fourth session, we will also formulate or think about research gaps. And finally, at the end, hopefully we will all be moved to really have a call to action on the many things that we need to do to realize the goal of eliminating cervical cancer around the world. I think I have a few housekeeping announcements to go through. This slide, okay, I go. Okay. We have prepared food in that other room. Some of you have already got your coffee from there. And during tea breaks, I think because we have a very packed program, just come and enjoy your tea and coffee and snacks in here. Of course, we hope that you keep your phone on silent. As is not unusual in the AIDS conferences, the IAS conferences, we may have, but we're not expecting any. This is just that there might be a peaceful protest. Do not interrupt or interfere. I think Hillary Clinton once said, it's not an AIDS conference without a protest. So the IAS team, having been a conference chair for several sessions now, it's something that the IAS team is very equipped, inshallah, to handle, but we're not expecting any. So let's start with a program. And we're going to start off with a video from a cervical cancer survivor, Sally Agallo, who lives with HIV, and she has survived cancer 3 times and is a lived experience advocate and representative of the Our View, Our Voices initiative of the NCD Alliance, whom I should acknowledge is one of our partners here as well. Unfortunately, Sally is unable to join us from Kenya as her visa was denied twice, but has gracefully agreed to share her story with us on video. So let's hear Sally's story.
Hiking really helps me to refresh. I've gone through so much in life, and at one point I even went into depression. When I go hiking, all this goes away, at least for that moment. I had my first baby in 1999, and unfortunately after 2 days the baby died. And I asked God, why? Why did you show me and then take him away? So then I got pregnant almost immediately. And during this second pregnancy is when things started happening. I was very sick. I could get pneumonia, I could get malaria, I could get sick all the time. At 7 months, the baby was saved, put in an incubator for a few days, and he passed on, another boy. A lot of blood samples were taken just to find out why I had a very low immune system and these things were happening. I walked into a room for my appointment and the doctor said, "Uko na ukimwi," meaning you have AIDS. There was no treatment for HIV at that time. It was like a death sentence. I was very bitter with life, I was very bitter with myself, I was very bitter with God, and one day I told him, I want to die. I will take my life.
In most of sub-Saharan Africa, the biggest causes of death or illness have been due to infectious diseases. Malaria, TB, diarrheal diseases in children, and HIV. Because of that, a lot of attention in terms of resources have been directed to these diseases. NCDs, or non-communicable diseases, on the other hand, are emerging problems, increasing a lot over the last 20 years, such that now NCDs cause about 30 to 35% of mortality and 50% now of hospitalization and illness. The chances of getting an NCD if you have HIV are higher. For example, cervical cancer is as high as 6 times more likely to occur in people living with HIV.
In 2007, I get bad news again. I go to the hospital in the morning and the doctor explains to us that because of your HIV status, you're exposed to the HPV, human papillomavirus, and as a result, you have stage 2 cervical cancer. The pain that I've gone through with cancer, I wouldn't wish my worst enemy to go through it.
The understanding of the link between HIV and NCDs is growing day by day. One of the proposals that have been made through a lot of research by WHO and other research agencies is integration of care. In Tanzania, there are 6 sites at the moment which explores the integration of diabetes and hypertension into HIV programs.
HIV nowadays doesn't kill. What kills today is NCDs. So we need to take care of NCDs with HIV together. The clinic has been growing. We started with 10 clients, but currently as I'm speaking, we are having 250 clients. So I think the project has been very successful.
We screen for hypertension and diabetic. People, they are being diagnosed early, and also they are getting all treatment together. And we are giving them counseling every day, so stigma also is reduced.
NCDs continue to increase, but we have good models which we have shown that can work. And it's possible, if all this is implemented, that we can turn the tide on NCDs and also HIV together. So the future is bright.
I would be very happy that before I die, I would see the integration happen. So all this put together would make a big difference. After going through my traumatic experience, and now it's been over 20 years, I've become a health advocate. We have support groups and we meet just to share our stories and how we're coping, giving hope with whatever someone is going through. I must say that I am not a survivor, but I'm a warrior. Let us keep hope alive.
Hello everybody, my name is Sally Agalo Kwenda. I live in Kenya, the capital city, Nairobi. I wish to share my story with you today of what I've gone through in life. Today I am 53 years old, and not many women like talking about their age because of, I don't know why, but for me I've gone through so much, and that is why I am never ashamed to say how old I am. And this is because in the year 1999, I thought I would die, or I actually attempted suicide as a result of having been tested for HIV, and there was no counseling done. So the person who gave me the result just said, you have HIV, or it was actually AIDS that time. And I knew that I was going to be wrapped in a black polythene and buried, so I didn't wait for that. Since I was living in Mombasa, I chose the ocean as my burial site. In the middle of the ocean, I dived. I'm a non-swimmer, but I dived into the ocean and hoping to die. But God had his own plan, so I was rescued. And from there, I was saved and taken to the hospital, of course, first aid and everything that happens. And because attempted suicide is like murder, I was to be arrested. But I told them that give me an opportunity, because when I was in the ocean, I had a vision. God spoke to me and told me, I want you to go and save my people. If you think you have issues, go and see how much other people have. So they thought I was a mad woman, and they called a psychiatrist who talked to me and said, okay, this woman is depressed. The reason why I was doing this is because I did not get support from my husband. By then, I'd lost 2 babies, one at 2 months, another one at 7 months. And my husband did not give me any support at all. And all I faced was stigma from my in-laws. And I thought the best thing was to die because I did not have any kind of support from them. I really thank God for my sister, my family. I'm a last born, and so my sister and my other siblings really took good care of me, and I must appreciate that. I also want to appreciate MSF, Medicines Sans Frontières Belgium, who took me in because of my story. I know some people are sacked because they have HIV. I was given employment because I had HIV. They trained me as a HIV/AIDS counselor, and today I'm glad that I can talk to other people. The challenges I went through is treatment. At that time, there was no antiretroviral treatment, and it was very expensive if there was any. The only drug that was there was Septrin, and I'm allergic to sulfur, so I wasn't able to take that. Miraculously, I got better, I got okay, and I'm happy that I'm here today to share my story. So when I was with MSF, we went through we had a very good medical cover. And at some point, I was screened for cervical cancer and actually turned positive for the human papilloma virus. And further tests revealed that it was actually cervical cancer and it was already in stage 2. It was another shock for me because I had already lost 2 babies. And so the doctor is telling me that for us to do this, we have to do an immediate intervention. And that meant that I was to do total hysterectomy, removal of my womb and everything else. For 2 months, I could not believe that that was happening. But anyway, I went for that. I accepted, signed the consent with him. That time we had already come back with my husband, we signed the consent and the surgery happened. But as soon as that happened, my husband could not take it and he left to go and look for another or to look for another relationship, a woman who could give him babies because I wasn't able to give him babies. That is stigma that I faced. It wasn't easy for me, but yeah, that is how life is. Sometimes people say that when life throws lemons at you, you can make lemonade. Sometimes even that picking those lemons and making the lemonade, the strength sometimes is not there. At that time, I did not have the strength. As if that was not enough. In the year 2007, I couldn't believe that I could not have babies anymore. And so the follow-up continued. And unfortunately, in 2010, again, I was found to be having colon cancer again because I did not go through radio and chemotherapy because of my immunity that was very low. So unfortunately, I got cancer again in 2010 and I've now lived with a condition called ostomy for the last 13 years and it is permanent. Getting ostomy pouches in Kenya is a very big challenge, and so I formed an organization, Kenya Ostomy Association, to be able to support such people. And at this moment, I would also wish to address policymakers. And I would say that so far I've been talking about my own story, but there are many other people. If anyone else was given this opportunity, I believe they would share their stories. So it's not just me alone, but many others. Yeah, so in fact, there's more and more people living with both HIV and cancer. I'm not alone. As the global population of people living with HIV is living longer, thanks to increased access and uptake of the ARV treatment. The risk of non-communicable diseases, including cancer, cardiovascular diseases, depression, and diabetes, this will only increase. At the same time, evidence shows that women living with HIV have a 6-fold higher risk of cervical cancer than women without HIV, as well as higher risks of recurrence. That is following treatment. In 2018, around 5% of all cases of cervical cancer globally were attributable to HIV, which 21% of those in the region were from my own region, Africa. Faced with this reality, there has been growing recognition about the importance of integrating NCDs and HIV response with the adoption of high-level political commitments calling for the integration of HIV services in NCD screening and treatment for people living with HIV. In the political declaration of HIV and AIDS adopted at the UN General Assembly, which happened in the year 2021, governments committed to ensure that 90% of people living with and at risk of and affected by HIV have access to NCD prevention and care services, including for mental health by 2025. I hope I live to see this happen. In doing so, governments with the support of global health organizations, donors, and private sector and civil society must coordinate, fund, and drive local context responsive agendas for HIV NCD integration to achieve the 90% integrated care target, which emphasizes person-centered care and considers the whole care cascade from prevention and diagnosis to treatment and as well as retention. One of the reasons why I'm sharing my story is precisely to sensitize policymakers about the importance of taking a context-specific approach for NCD integration and of listening to their communities' experiences and needs when designing their national policies and strategic plans. This is important not only to identify barriers of integrating NCD services into HIV-specific programs, but also to think about the opportunities to scale up these programs to the wider population and supporting health systems work towards achieving the ultimate goal of universal health coverage and ensure no one is pushed into poverty due to out-of-pocket payments in healthcare. The impacts of integrating NCD services into HIV programs can have a positive impact from a clinical point of view, associated, for instance, with earlier diagnosis, access to medication and take-up of treatment, but also from a societal point of view. Consider the cost of associated, consider the cost associated with traveling to clinics, travel-related meals, childcare and elderly care, and also loss of work opportunities. But the need for a people-centered approach and context-specific approach to integrated health services has also been acknowledged by the Global Coordinating and Funding Institution for HIV and AIDS, such as the UNAIDS, PEPFAR, and the Global Fund, and reflected in their multi-year strategies. This moves towards a people-centered approach is fundamental to break siloed approaches to funding and implementation of integration programs. In fact, all stakeholders must advance and share the evidence base on equitable, impactful, cost-effective, gender-sensitive, and age-responsive integration strategies to meet the growing needs for prevention, treatment of people living with HIV and cancer, as well as NCD more broadly. This is why I'm talking to you today and sharing my story. I wish to inspire people who may be losing hope and to urge policymakers and health system funders about the challenges and importance of adopting an integrated approach to disease prevention and management. I thank you all for listening to me and wish you a very productive discussion.
An amazing story of, courage and resilience, and that sets the scene really well for the rest of today in a call for a person-centered approach and integration and evidence-based practices. I would now like to introduce our second speaker, who really needs no further introduction, especially to the HIV world, Meg Doherty, who is the director of the HIV program, HIV, hepatitis, and sexually transmitted infections program at the World Health Organization. And Meg is going to share with us outline the burden of HPV-related cancers among people living with HIV and WHO recommendations for vaccination, screening, and treatment.
And thank you very much, Deba. And I'm really pleased to be here. And just to note that for WHO, cervical cancer elimination has been one of the priorities and flagships of the Director General since he started. And now he's in his second term for another 5 years, and it's maintained as one of his priorities. And so, to be honest, it's very nice to be here to be able to share the work of my colleagues, especially Shona Dalal, who hasn't made it, Maribel, who will be on the agenda later today, but virtually, and Morcor Newman, who will join in the afternoon, and of course our NCD colleagues who are doing many other NCD work this week. It's a very busy week, I would have to say, in the STI field and also in Women Deliver. So it's exciting that this is coming up in all of those agendas. So we already had the acknowledgement. I would just like to say as well that we also are remembering our colleague Glenn Thomas, who passed away 9 years ago, I guess it was, with the MH17, and he was a member who was coming to the Melbourne meeting as well. And I know many of us are thinking of those people who aren't here with us today. So on to the epidemiology and the HPV-associated cancers among people living with HIV. I think this evidence you have seen, you heard it in the messaging already from Sally this morning, that people living with HIV have a known twofold increased risk of high-risk HPV acquisition and a twofold decreased risk of HPV clearance, putting them in general at a much greater risk of acquiring and going on to cervical cancer. And in the most recent studies and systematic review done by the WHO, is women living with HIV have a 6-fold increased risk of cervical cancer versus women in the general population. But we are also not just looking at women, and I think increasingly we realize that we have to also look at men, and that's something that our team is thinking about daily. And looking at anal cancer is higher in people living with HIV, 85 per 100,000 in men who have sex with men, 32 per 100,000 in heterosexual men, 22 in women living with HIV. So again, we can see that the cancers are not just associated with cervical cancer for HPV. So there's much more that we need to do in this field as we move forward. So when we look at the cervical cancer incidence and mortality in 2020 from the data that come out of WHO and various systematic reviews, we have seen that we have about 600,000 cervical cancer cases, half of those having 300,000 deaths per year. And our mortality range across different countries, and by the intensity of the color on the maps, range from 1 to 56 per 100,000, with the intensity as well as the acquisition highest, as you can see, in the African region as well. So we know that we have geographical differences and variability as well, and that was really put a face to it with the discussion, with the presentation made by Sally, that it's hard to have treatment for HIV, but then be at risk of passing away or having severe morbidity due to a cancer that could have been prevented. So that has led us to really look at access to HPV prevention and vaccination, cervical cancer and screening, and really looking at what we can do by ensuring everybody who is at risk of HIV has treatment as well as viral load suppression. So this is the data from a large systematic review and looking at the population attributable fraction of women with cervical cancer living with HIV that came out in 2018, but then really guided where WHO went with our recommendations. And again, you can see that greater intensity in sub-Saharan Africa, where we need to put much of our emphasis. But as you have heard, women and girls living with HIV have higher risk of getting HPV, lower risk of clearance, faster progression, lower regression of precancerous lesions, as well as higher recurrence in a younger age at presentation. So overall, all the factors that you look at for cervical cancer do not fare as well in young women or women living with HIV. So that's what prompted our DG to put forward this global cervical cancer elimination agenda and initiative, which has various thresholds and targets that will bring us to the SDGs 2030, which include 90% of girls vaccinated with HPV vaccination by the age of 15 years, 70% of women screened with a high-performance test, and we'll go through that in a bit, between age 35 and 45, and 90% of those women identified with cervical cancer having some level of treatment and care. And elimination, and we're talking a lot about elimination while being here in Australia and at this conference, is defined as less than 4 per 100,000 cases. And I think this is also a 30% reduction in mortality. So again, the actual reaching elimination as a public health threat can be very high in terms of the ambition, but I think in many places this could be implemented and achievable in certain sections of the parts of the world. What we know right now is we have 134 countries that have HPV vaccination in their national program. So green is showing that it's either fully there or partially there. But what we're missing is certain parts, and especially we were just discussing this morning with my colleague from Expertise France, that sometimes West and Central Africa and Francophone Africa is left behind, and we can see certain parts of Asia as well are left behind with having a full HPV vaccination program, and this should be a priority for all of us. And eventually start thinking about how we vaccinate boys. That's something that I'm very concerned that we haven't really brought yet forward. In terms of the impact of COVID on the vaccination, I think there's been a lot of discussion about zero vaccinated children, but we've seen, at least with the HPV vaccination, that it started to recover and surpass the pre-pandemic levels. So, and that's primarily, I think, also due to some very exciting news that have come out about the vaccination schedule and simplification of the vaccination schedule. Let me just see there. Here we go. So the new WHO recommendations on HPV vaccine should optimize our vaccination coverage. For girls 9 to 14 years of age, there is a 2-dose schedule starting at 9 years old, but there is now a new option for a 1-dose schedule for those from 9 to 20 years old. Now, for people living with HIV or those who are immunocompromised, we still recommend at least 2 doses, perhaps 3. But this could be a real game changer, and I think my colleague Sinead will be talking about HPV vaccination later on and what this 1 dose might look like for other parts of the world. And to be honest, I think also we've seen reduction in prices of the HPV vaccine, and that also is going to be a game changer in terms of making it more acceptable and accessible. So what this slide shows is actually a number of countries that have already switched to the 1-dose HPV vaccination schedule. And what's great to see is that it's already taking off in certain parts of Africa, in the Latin America, in Europe, and also in Asia. And also in Gavi countries, there's going to be some support to the 1-dose vaccination, especially in Togo, Bangladesh, Nigeria, and India. And we do believe that this really will be a game changer. So we hope to see more vaccination infusion. And once we have the 1 dose and looking at what can happen with younger people and younger boys, I think we might be able to see greater coverage and faster elimination as we move forward. In terms of the lifetime screening coverage, now if we're talking vaccination, now we move on to screening. Among women aged 30 to 49 years by country around the world, again, we see red being where we have gaps, enormous gaps in coverage of one-time screening. So in many ways, we have a lot of work to do in Africa and also in India to increase that at least first screening and at least another screening during the lifetime. And there has been a model that WHO's Cervical Cancer Elimination Modeling Consortium has looked at, where they've put together and looked at 3 dynamic models in South Africa. And I may not do this model justice because this is the work of Shona Dalal and our team, but really looking at the potential for elimination of cervical cancer through both the vaccination and the screening approaches within the next century. Because if many of you looked at some of the models, they had a very long horizon going out 100 years. And I think many of us would like to see that come a little forward. So in many ways, in the short term, there can be a huge reduction or a substantial reduction in actually this time to cervical cancer elimination. And the largest impact was not just on vaccination, but the additional screening and treatment. And those are seen with the dotted lines that we can, achieve our threshold among all women and women living with HIV if we actually can bring in the greater screening earlier among women living with HIV. And hopefully I've gotten that right, but my colleague Shona Dalal can answer that should we need to, if you have further questions on that. So those are all the inputs that have gone into our guidelines, and we have guidelines on recommendations on screening and treatment for cervical cancer among women living with HIV that are in our NCD recommendations guidelines as well as our HIV guidelines. And when we looked at the recommendations, we had several questions to answer. At the age of when to start screening, the screening strategies, treatment or no treatment, and follow-up, and the age to stop screening among people living and women living with HIV. And from there, we also looked at different approaches to screening and treating. And one called screen and go right to treat, sort of like a treat-all approach, or screen, triage, and treat. And sometimes people would say, well, and myself included, why would we need to stop by triage in the midst? And I think at this point it's because there's such a high burden. And when the guideline committee came together, these are the recommendations that were made, that actually a triage test can actually help hone in those women who actually need to be treated immediately. So in the traditional cervical cancer recommendations, we were using either VIA, the visual inspection of the cervix, or cytology, sending a smear off to pathology. That would take time. Often women would come in, maybe get their diagnosis very late. But in our new primary screening, we're now using high-performance DNA testing or our nucleic acid testing, or mRNA testing, which has not yet been, we don't have a recommendation for women living with HIV because we're looking for more evidence there. But for the general population, using a high nucleic acid testing approach, either DNA or mRNA, with a screening and treat approach for all women in the general population is recommended. For women living with HIV, because there's such a high burden in that population, a second step was put in of triage, looking for high-risk HPV DNA, either 16 or 18, or cytology, colposcopy, or VIA in the middle there. I think this was primarily to be able to ensure that all women who needed care were actually going to get it and that there would not be over-treatment, especially in younger women where there may be some regression of the lesions. Again, the treatment is now not just LEAP or excision, but thermoablation, and I think that's going to be an important piece of having those tools available in low and middle income countries to be able to actually treat appropriately. Now again, what are the summary recommendations for women living with HIV? I'll just put here, it's using a primary HPV DNA as a primary screening test, starting at age 25, so earlier than all women, and screening every 3 to 5 years at that interval, which again is a shorter interval than all women with the general population. When providing the HPV DNA testing, WHO is recommending either using a provider sample or a self-sample. And we've seen that self-sampling is going to be the way of the future, like self-care is, self-testing, and I think that will increase the first screening test. So one great thing that we've seen since our guidelines have come out is that we've had, within 2 years of the guideline release, 50 countries have adopted the WHO recommendations for screening and treatment, and we expect 19 more to come on before the end of 2025. So in many ways, I think these guidelines, sometimes people say it takes 10 years for the infusion of the dissemination of the new guidelines. This one has gone relatively quickly because I think the need has been so high. We have guidance now that have come out not only from our WHO HIV program, but also the NCD program about how to scale up the screening and treatment approaches. And let's see. The other new recommendation that we have coming out is that it's recommended that this should be recorded in all of the routine monitoring. I think what we've seen overall is that we've not been able to document well what's happening with cervical cancer around the world. And if this is brought into both the national screening and the national strategic information tools, then we'll have a better sense of, are we achieving our goals of cervical cancer elimination, and when we will achieve those, can we move that a bit faster than we have in the past? And the last thing would be to say that we're working very closely with our non-communicable disease colleagues, and I think Sally brought that forward, and this is the person-centered care approach. Yesterday, we were with another group talking about integrated person-centered care, and certainly cervical cancers are part of the future of many people living with HIV, but many people in general. And so therefore, we want to be able to show that you can screen for not only cervical cancer, other cancers, breast cancer, lung cancer, but also look for non-communicable diseases, hypertension, diabetes, chronic pulmonary disease, mental health. And I think that's the goal of a future where we're really seeing a person-centered integrated healthcare system. Lastly, I just want to say we have a great set of advocates at WHO. They've really been working with community. I think we have great support from ministries of health. This is the opportunity where you have a lot of buy-in and a lot of desire to move this forward. So if you're coming in from a ministry or from a program, we would recommend that you try to move these recommendations and these guidelines as quickly as possible, because we have an opportunity now to reduce that time to achieving our elimination targets by quite a bit of years. So I'd like to thank all the other colleagues who provided inputs to this plenary, and I hope I've given you enough information to say cervical cancer elimination is possible if we actually implement the recommendations we have. And I would also suggest that we start looking at men and the single-dose HPV vaccine as we move forward. So thank you very much.
Thank you so much, Meg, for that excellent summary update of current WHO recommendations for cervical cancer vaccination, cervical cancer vaccination and screening. Our next speaker, and also for keeping to exact timing, our next speaker unfortunately can't be with us here today, although she's really been instrumental for helping us put this whole program together, and that's Azadeh Begaki from Unitate. She's going to be sharing her address by video. Azaki is a New Zealand pharmacist, and she's currently at Unitate as the cervical cancer strategy manager. And she's going to be speaking to us about Unitate's mission to accelerate the elimination of cervical cancer in low-resource settings. So, the video.
Good morning, ladies and gentlemen, distinguished colleagues and friends. Thank you all for joining us today for this important pre-IAS session. I'm sorry I can't be with you in person, but it's been an absolute pleasure working with the colleagues from the IAS and the chairs to organize the event. And I'm honored to be speaking to you today on how Unitate is increasing access to effective tools and delivery models for secondary prevention of cervical cancer. Unitate, a UN entity hosted by the World Health Organization, has over 16 years of experience making catalytic investments, addressing access barriers, and bringing innovation and quality-assured health products to those that need them most. We do this through strategic partnerships, and our areas of focus include HIV and HIV co-infections. Our investments have resulted in people in LMIC gaining access to over 150 life-saving products that form the backbone of public health response today. And you can see that our investment in cervical cancer started some time ago, as we recognize the inequalities as well as opportunity for saving lives and making an impact. We've worked hand in hand with the World Health Organization to help countries implement the strategy that will ultimately lead to the elimination of cervical cancer as a public health problem. We know that cervical cancer is largely an issue of access. In low resource settings, progress towards elimination targets has been held back by high cost of effective tools, ineffective screening methods, and ill-adapted treatment devices. With more than $70 million invested so far through our implementing partners, CHI, Expertise France, JPIGO, and UICC, we focus on secondary prevention of cervical cancer, working with governments to lay out the groundwork of screen and treat programs and introducing new tools and technologies so that we collectively reach the global targets and thereby contribute to saving many of the over 300,000 lives lost each year. To date, we've supported governments of 14 countries across 3 continents in a range of contexts to deliver integrated programs that have led to screening of over 1.1 million women. A third of those screens were with HPV tests. With our partners, we've secured price negotiations that have reduced the cost of HPV screens by 1/3 and cut the price of thermoablation devices by half, making treatment 10 times less expensive than with cryotherapy. Looking at some of those statistics across the countries, we see that of all the women screened, 28% were women living with HIV, and 36% of all women screened have been through HPV tests. Over half of the women screened with HPV collected their own samples, predominantly at facilities. And we've seen that women find self-collection easy and it's highly acceptable by them. And therefore, for the second wave of investment into cervical cancer, at Unitaid, we're focusing on unlocking the true potential of HPV self-collection so that women can collect their own sample without the need for a pelvic exam at a place and time of their choosing and using HPV tests so that they can be confident of the results. In practical terms, we aim to fill the research gaps around HPV self-collection outside facilities. So we'll carry out research to generate evidence, help inform global guidance, as well as national adoption and uptake. This will involve testing out different models of self-collection delivery and drop-off in communities. For example, self-collection kits being delivered and picked up by community health workers, or through outreach to them at their homes, or when they visit health posts or pharmacies. We'll also address 3 of the key elements related to self-collection, namely ensuring effective digital solutions so that women know about their opportunity to screen, have the results sent to them in a timely manner, and tracked throughout their care pathway so that they're not lost to follow-up. Secondly, grassroots level awareness raising and demand generation so that women know about the services and can advocate for their availability. And finally, ensuring optimized laboratory networks so that the samples are processed and the results returned efficiently. These investments will be made while we work with partners to address 2 key factors that continue to hinder progress, namely health financing and having affordable, effective tools. Unitaid remains committed to partnering with governments, industry, civil society, community groups, and other stakeholders in effort to achieve the cervical cancer elimination targets. Together, we can all help get rid of this preventable cancer. Thank you all so much for your time.
And once again, on behalf of IAS, I wish to thank Unitaid for their great support for this program. Now, our final speaker for this session is Karen Canfield, who's the inaugural director of the Daffodil Centre, a flagship centre of the University of Sydney, and a joint venture with Cancer Council New South Wales, Australia. She's a professor in NHMRC, Leadership Fellow of the Faculty of Medicine and Health at the University of Sydney, and her research involves evaluation and translation of new strategies for cancer control. And Karen is going to talk to us about making the investment case to catalyze the elimination of HPV-related cancers. Karen.
Thank you so much, Prof. Adiba, and thank you, Prof. Grulich, as well, and to the organisers for the honour of being here to speak to you today about this important topic. So, making the investment case to catalyse the elimination of HPV-related cancers, of course, starts with the impact case, and I'll take you through that. Firstly, though, my disclosures, to let you know I'm co-PI of 2 investigator-initiated projects as shown. So, of course, as we've seen, cervical cancer has an enormous and growing burden of disease. And as we've heard, it's 600,000 plus cases in 2020, estimated by IARC's Globocan, 342,000 deaths. But most importantly, this impacts women across the age spectrum, but it also impacts young women. In 52% of countries globally, cervical cancer is among the top 3. But in about 80% of countries, cervical cancer is the top 3 cancers in women under 45 years. So this leads, in fact, and unfortunately, to profound intergenerational consequences as well off the back of cervical cancer. So this is a really important and wonderful study done by Florence Guida and Valerie McCormack at IARC, published very recently. This is the impact of cancer, a cancer diagnosis, on maternal orphans globally. For all cancers in 2020, 4.4 million cancer deaths in women resulted in overall 1 million maternal orphans. But if you look on the right, those 340 plus cervical cancer cases by themselves generated 200,000 of those deaths, and that's about 20% of the total. And you can see that that really impacts particularly in women under the age of 50, peaking in the 40 to 44-year-olds. So this is incredibly important and relates to the investment case for investing in cervical cancer control. Now, as we've of course heard, the WHO strategy, of course, the 3 pillars of cervical cancer control, the 90-70-90 targets, 90% of young girls vaccinated by 2030, 70% of women screened a minimum twice in a lifetime by 2030, and scaling up to 90% access to cervical cancer treatment services. And the essential work underpinning these targets was really underpinned by work done by the WHO Cervical Cancer Elimination Modelling Consortium. So these are the results for modelling across 78 LMIC. This was our team now at the Daffodil Centre with a group at Harvard led by Jane Kim, and at Laval University in Canada led by Prof. Marc Brisson. So the first thing that we did in this exercise is we formally explored the potential of different thresholds for cervical cancer elimination, not only what we've now landed on, which is the 4 per 100,000, but an alternative threshold of 10 per 100,000 or an 85% relative reduction. The short story is that with scale-up of vaccination and twice lifetime screening, we found that all LMIC could eliminate cervical cancer according to all thresholds, and that this would be about, on average, at around 2070, but a lot of heterogeneity in when this would happen. Now, what does this mean for cervical cancer mortality? So this graphic now shows our results for the reductions in cervical cancer mortality over time. So if we look first at girls-only vaccination, the first strategy explored, you can see a dramatic fall in mortality, but unfortunately it's delayed by 40 or 50 years just because of that delay between vaccinating adolescents and preventing mortality in older women. With once lifetime screening, we bring that forward considerably, and then the purple line with twice lifetime screening and treatment scale up for cervical cancer, we can really move the dial. What this means is that the combined impact of the 3 pillars can result in both short and longer term population-wide benefits. So 300 to 400,000 deaths averted by 2030, around 15 million by 2070, and over 62 million over the course of a century. Now, back to the investment case. What does this actually mean? Well, at the time, working with Melanie Bertram and WHO economists, we used these results to estimate that the return on investment of this investing in scale-up to the three pillars was about $3.20 return to the economy for every dollar invested through 2050 and beyond. But it rises to $26 when we think about the wider benefits, improved health on families and benefits to society. Now, moving forward and thinking specifically about the subgroup of women impacted by HIV, it's really important to understand that the initial elimination modelling was across the general population and didn't explicitly model interactions between HIV and HPV. This has been happening since, and this is one of the studies that's been done by Michaela Hall in our team using Tanzania as an example. It shows similar to the results shown by Meg. Firstly, you need to screen more frequently in women living with HIV. You need to combine screening with vaccination, and you also need to focus on scale-up of access to cancer treatment services. But if you can do all three, the benefits in this subgroup will be equalised to the general population. In fact, it's possible, conceivably, to accelerate elimination in the subgroup of women living with HIV if they can be reached for HPV-based screening on a frequent basis. So, as you've heard already, in LMIC, the WHO screen and treat guidelines provide models for the effective implementation of primary HPV screening. And of course, the key change in 2021 when these new screen and treat guidelines came out was that WHO now recommends using HPV detection as the primary screening test rather than VIA or cytology as the primary test in both the general population and in women living with HIV. Now, this is a complicated looking graphic, but this is the modelling that was part of the underpinning of these guidelines. This is modelling using the Tanzania example for women living with HIV. And this is showing a range of strategies, the lifetime impact of a range of strategies, intervals, starting ages, etc. The really short story is you can maximise the benefits and minimise the harms by using HPV testing, not VIA testing, and by using triage testing in women living with HIV. So this lower part of the graphic shows strategies based on HPV screening, which, as you can see, are associated with much lower average numbers of pre-cancer treatment, lower harms in women living with HIV compared to VIA screening. And the benefits are maximised if you can screen more frequently, of course, and this helped underpin WHO recommendations to screen 3 to 5 yearly in this group. So what's the challenge now? It's really about making HPV testing, of course, accessible and affordable to all women, including women living with HIV. This must be a priority. And there's some good news, and there is perhaps a silver lining off the back of COVID, that some of the systems for HPV screening are becoming more broadly available and established infrastructure in LMIC. So this is one example, thanks to Dr. Steve Badham, who's here today. A 54% increase in gene expert instrument numbers has been observed across the Pacific Island countries and territories since before COVID. So that, I think, gives us hope that the infrastructure is being established. Now, you heard from Azada from Unitaid earlier, and there's a very important exercise going on that Unitaid is leading at the moment to do an updated landscape for HPV tests and for triage technologies. And we're supporting this at the Daffodil Centre. These are the algorithms shown here for inclusion in the landscape report, and I won't go through them in detail. But in essence, for HPV tests, what we're looking for is not only market authorisation, but clinical validation according to appropriate criteria. And some very preliminary results show that we now have a landscape where there are potentially 28 primary tests fulfilling that criteria, and we certainly hope that that will provide impetus for market competition and market shaping going forward. So what's the road forward now in terms of encouraging the necessary strategic investments in cervical cancer elimination? Well, just a few closing thoughts. Firstly, I haven't talked at all yet about Australia, the country we're in, but I think continued high prioritisation of the elimination agenda in high-income countries is part of this. In Australia, this was the first country in which modelling was done to show the possibility of elimination. We put it out there back in 2018 that elimination could be conceivable within a decade in Australia by 2035 or so. And off the back of this, Australia has now developed a draft plan, a vision, and 10 strategic priorities to achieve cervical cancer elimination by 2035. And the vision is articulated as an Australia where preventable cervical cancer is a disease of the past, in which Australia's diverse communities have equitable access to information and to culturally safe and inclusive vaccination, screening and treatment services. So I think it's very important that high-income countries continue to make this prioritisation. In our region, a key step recently, in October last year, was the release of the strategic framework for the elimination of cervical cancer and control at the regional committee meeting of WHO Western Pacific Office. And I think this is a key step in enabling countries to move forward with the elimination agenda. One important demonstration of impact that you'll hear about more from Prof. Andrew Vallely in the next session is a major program of work called Elimination of Cervical Cancer in the Western Pacific, which is showing that it's possible to scale up rapidly in low and middle income countries. And in fact, the idea is to set two settings, the Western Highlands of PNG and Vanuatu, on the path to elimination by 2025 and show it's doable. What do we need to support countries going further? Well, our team believe that it's really these numbers, the impact case and the investment case, but localised to a country or a member state situation that will really help move the dial. And so we're working with IARC to develop an elimination planning tool that will provide countries with the details of what can be achieved under different scale-up scenarios, different decisions about male vaccination versus female-only vaccination, and so on and so forth. This elimination planning tool, we hope, will be launched by the end of this year and will be approved over time to include specific predictions for women living with HIV. And there's an example here that shows country-specific predictions. You can work out your elimination year, you can work out the return on investment, and so on. So it's nearly 3 years now since WHO launched the elimination strategy. And of course, with COVID, impacts COVID delays in between, but some good news and silver linings as we hope we emerge. I think it is extraordinarily important that we all reaffirm the commitment now to achieving scale up of the 90-70-90 targets, and that we reaffirm the commitment to accessing women living with HIV and to offering appropriate screen, triage and treat services to that critical group of women. It's really important that we also emphasise that doing so will have profound impacts not only on women, but for the future, and to really maximise, I suppose, the gains for society and for future generations. So I'd like to just finish by acknowledging the very many collaborators who've been involved on that rapid tour of some of the work that we've been involved in, and also to acknowledge the women and people who have been impacted by cervical cancer and HPV-related cancers. Thank you very much.
Thank you so much, Karen, for really convincingly, at least to me, for making the case for cervical cancer elimination. Really, we have the vaccine, we have the tools, including self-sampling tools. There's really no reason why we can't reach those goals that we have set ourselves. So I'm sure all of you agreed that we've had a fantastic start to the day's meeting. We will take questions at the end of the second session, because we're going to allow you to have coffee and some cookies across the corridor. We want to start back on time at 10:30, so if you wish, you may bring your coffee and cakes into the room. And it leaves me to once again thank you all our fantastic speakers who are here with us, as well as those who shared their presentation online. Thank you.